signs like it can be presented as a lump in the breast, it can be pain in the breast, or it can be discharge from the nipple. Any of these presentation can be present when there is an underlying disease of breast. It can appear as a single complaint, or else it can appear in combinations also. Either three of these together can occur, or else individually also these can occur when there is a disease happening in the breast. So before moving on to the diseases, we will just see the anatomy anatomy of the breast. So breast, it is the modified sweat gland lying on the pectoral fascia and musculature of the chest wall, and it is surrounded by skin and subcutaneous fat. And the extent means how it is extending transversely, it extends from the side of the sternum to near the mid axillary line, and vertically it extends from the second to sixth rib. That is the location. And the superolateral part of the breast, it is prolonged, and it is prolonged upwards and laterally towards the axilla, and there it forms the axillary tail of Spence. That is another important structure related to the breast. Then about the nipple, it is a cylindrical or conical eminence which projects from the below the center of the anterior surface of breast, and it usually lies at the level of fourth intercostal space. And this nipple, it is traversed by 15 to 20 milk ducts, that is the lactiferous ducts, which open by minute orifices on its wrinkled tip. That is about nipple. And then the base of the nipple, that is encircled by a more pigmented skin, and that is called areola. And the skin of areola contains numerous sebaceous glands called areolar glands, and this becomes enlarged during pregnancy and lactation, and it form the Montgomery tubercle or Montgomery glands. Then about the structure of the breast consists of gland tissue, fibrous tissue, and fatty tissue. Um, then other than that, when we see about the arterial supply, three major arterial supply is there to the breast. There are perforating branches of the internal mammary artery, then lateral mammary branches of lateral thoracic artery, and third source of blood supply comes from the pectoral branch of acromiothoracic artery. Venous drainage, it is classified as deep and superficial veins mainly. uh, Deep veins drain along the roots of the corresponding arterial supply. Superficial veins are quite rich, and the superficial veins drain into the internal mammary vein and axillary vein. Lymphatics, there are the lymph vessels of mammary glands originate in a plexus, and that is connected, means in the interlobular connective tissue and the walls of lactiferous ducts they are present. There are minute vessels. And when we see the lymph nodes, mainly the subclavian trunk, the Rotter's nodes, the lymphatics from the inferior and medial part of the breast appears to the rectus sheath. And these are the main lymph nodes, or the intercostal lymph nodes are mainly involved in the lymphatic drainage of breast. Next.
Ma'am,
No. No. So next, an important point regarding the disease of breast is examination of the breast. Means how the breast should be examined. The important points. So first thing is the physical examination of the, and in that the local examination. Before we move on to the examination, we have to ensure few things. That is, we should place the patient in a calm and adequate private place, because adequate privacy have to be given to the patient, and the area should be calm also. That have to be ensured. Then the room should be well lighted. That is, for the proper examination, proper light source should be there, so the patient should be placed in a well lighted room. Then while examination, for examination, the body parts to be exposed. So in case of breast examination, even though uh, the level of breast, it is not the examination should not be confined to that part. Expose the body parts up to the waist of the patient. That is the adequate exposure needed for proper examination. So these things have to be kept in mind, or these have to be ensured before the before starting the examination. And first thing, which we have to see is the posture of the patient. Means in what and all postures the patient can be made to lie or sit for proper examination. The patient can be made to sit, means in sitting position examination can be done, in semi recumbent position it can be done, recumbent position it can be done, and bending forward position. As you see in the image, you can see different postures the patient can be made to sit or lie comfortably. Then next is the position of the arms. So while examination, it's not only about the breast region we have to uh, consider. The position of arms also have to be maintained properly so as to facilitate a proper examination. So it is told that the position of arms, the arms should be either it should be by the side of the body, or the arms should be raised straight above, or else the hands should be uh, kept on the hips, pressing against, so that there will be a relaxation. Means in such a way the arms should be placed. So when we consider the examination, this is also a important point that have to be seen. So first is post the how the examination room should be, privacy, that calm atmosphere, exposure, that too up to the waist. Then posture, sitting, semi recumbent, recumbent or bending forward position. Then position of the arms, arms by the side of the body, arms raised straight above the head, hands on the patient's hips, pressing and relaxing as the surgeon suggests. So that should be the position of arms. Next, it is the quadrants. So, quadrants of breast, it is divided into four quadrants: upper inner quadrant, upper outer quadrant, lower inner quadrant, and lower outer quadrant. So, quadrant wise examination have to be performed. That also means that is another important point that have to be seen. Then it is about the detailed examination. So, first thing is inspection. Inspection, first it is about the breast. So when we consider the breast as a whole, what are the things we have to inspect? First thing is bilaterally the inspection have to be done. When examining, if the patient is having complaints in regarding one breast, then also the examination have to be done in a bilateral manner. Both the sides have to be considered. Then the position, then size and shape. Is there any variation in the size and shape? Is there any puckering, dimpling, or is there any swelling or ulcer present over the breast? These kind of things have to be noted as a gross, in a gross manner. Then if there is a swelling over the breast, then what and all things have to be seen? One thing is the color and texture. Means the swelling over the breast, how it will be. So the color and texture of the skin over the swelling, that have to be seen. Then if there is any presence of engorged veins, that have to be seen. Then if there is a swelling, the number, how many swellings are there, that have to be noted. Then as you see in the picture, if there is any dimpling, any retraction or puckering, such kind of features if it is present, that have to be noted. Then there is a classical sign of breast cancer. In the middle image, you can see that is pudy orange sign. That is the classical sign of breast cancer. Due to the infiltration, the skin is being pulled backwards, and that will cause that kind of appearance over the skin. That is pudy orange. So if there is any kind of that kind of features, that also have to be noted. Then if there is any nodules, any ulceration, any fungation, that also have to be noted on inspection regarding the swelling over the breast. So breast as a whole, if there is any swelling, in detail the examination of that swelling. Next is the nipple. Nipple, when you consider, first thing is whether the nipple is present or absent, whether both the nipples are intact, both sides it is present, or if there is any abnormality that have to be seen. Next is retraction, whether the nipple is retracted, that also have to be checked. Then position, is there any deviation, or is there any difference in the position of that nipple when we compare both the sides. Then the number, means there are conditions when there is more than one nipple, means one side more than one nipple can be present, so the number have to be noted. Then the size, shape, the surface, if there is any discharge from nipple or not, all these kinds of things have to be noted when you examine the nipple. The next thing is areola. So we have told what is nipple, what is areola, that is over. So after nipple, the areola have to be examined, and areola also same. Means in carcinoma conditions and all, there will be so much of this skin manifestations will be there. So in regard with that things, it should be it is an important thing that we have to note the surface texture, color, etc of the uh, uh, means overlying skin. So in areola also, the color, whether the pigmentation that is there, it is normal, it is if there any discoloration that have to be seen. Then the size, surface, texture, all these have to be seen about the areola. Then it is about the arm and thorax. Arm and thorax, what happens is that mainly cancer and cures, means there will be skin manifestations as a result of this carcinoma breast. There can be skin manifestations, so that have to be checked. Means the uh, uh, adjacent structures. So arm and thorax have to be checked for these kind of skin manifestations. Then there can be brawny edema of the arm due to lymphatic obstruction. There can be edema in the upper limb, so that have to be checked. For that, apart from the breast as such, the arm and thorax also have to be checked. Then similarly, what else? The lymphatic system, that is the axilla and supraclavicular fossa mainly. It is to check for the lymph nodes. Is there any swelling, or is there any enlarged lymph nodes in the axillary region or supraclavicular fossa, that also have to be seen for. So these are the main points which we have to see in case of inspection. So breast as a whole, then if there is any swelling over the breast, that have to be examined in detail. Then the nipple, areola, arm and thorax, axilla and the supraclavicular uh, fossa. So that is the inspection. The next is palpation. So palpation in all the postures, whatever we have told, we have to go for palpation. That is, while doing palpation, it should be done with the palmar surface of fingers with hand flat. That should be the uh, positioning of the hand while doing the palpation. And as I have told in the beginning, the quadrants, all the quadrants should be palpated. Means um, here you can see there are different methods told. Means it can be done in a circular manner, it can be done in a longitudinal manner. So in that different ways, any palpation technique, it is okay, but all quadrants should be palpated systematically. That is an important thing we have to consider when we are dealing with the palpation of the breast. And in as a whole, the breast have to be palpated. Then we have to palpate behind the nipple. We have to look for any discharge, means while palpating, if there is any discharge on pressure, is there any discharge or something, that have to be checked. And if on palpation a lump or a swelling is present, then normal lump examination, like is there any how the surface is there any discoloration. Then on palpation, if there is any rise of temperature, if there is tenderness, what is the exact location of the lump, how many are there, how is the consistency, means whether it is fixed to the skin, all these things have to be checked. When fixity to skin, that can be tested in different ways. That is, the tumor can be moved side to side or up and down. So if the tumor is fixed, what happens? There will be tethering of skin, that is there will be pulling back of the skin if that is if the tumor is fixed. So while moving, if it is fixed, there will be dimpling or tethering of the skin. Similarly, when we try to um, move the tumor, the skin is not able to slide over the tumor if there is fixity. Then skin of the tumor cannot be pinched up. Then purity orange, if it is present, that become more prominent when we do, when we move the tumor. So these kind of um, mm, features we can see while examining or while doing the palpation, especially to check the fixity to skin. Then it is before the assessment, another things we have to see is the uh, first thing we have told about fixity to skin. Similarly, fixity to the breast tissue, underlying fascia and muscles, to chest wall. These kind of things also have to be checked for in case of lump. Then palpation of nipple, already told, it should be checked for similar way. The tenderness, temperature, discharge, all these kind of things can be noted in after doing palpation of nipple. Then it is about the examination of lymph nodes, pectoral, central, apical, cervical, all lymph nodes, adjacent lymph nodes have to be examined properly. Then in addition to this, we have to go for general examination. That is, to examine for metastasis, we have to uh, do the general examination. By that, there will be we will be getting any kind of specific features regarding the metastasis. That idea will be available once we are doing a general examination. So that is about the palpation. Next main thing about examination is the triple assessment. Mainly in case of breast tumors or breast disorders, the triple assessment it involves, one is clinical, that we have told, that is the examination part. Then it is imaging, that is USG, mammography. These are the imaging techniques that will help in the assessment of the disease. Next is pathological. Pathological, it is the FNAC or biopsy. These are the triple assessment which is um, applicable in case of this uh, assessment of breast disorders. Clinical, imaging, and pathological. Clinical, it is mainly about the examination. Imaging, it involves USG and mammography. Pathology, it involves FNAC and biopsy. So these are the examination part of that breast. Now we will move on to the disorders of breast. Disorders of breast, mainly it is divided into congenital, inflammatory, proliferative conditions, neoplastic, and all. As per the syllabus, all kind of disorders are not included, and of that the main we will be discussing today. Each and every points, it is not told in the syllabus also. First thing is about the congenital anomalies of the breast. So in that, we know congenital anomalies, it can be one term, it is amasia. Amasia, AMAZIA, that is absence of breast. That is, sometimes it can be associated with the absence of sternal portion of the spectralized major. So that is one condition, amasia, when there is absence of breast. Then another condition is athelia. Athelia means absence of nipple. That is also rare condition. Then another one is polymasia. Polymasia means accessory breasts are present. That is mainly we have told about a milk line. So their accessory breast will be present. Then another thing is supernumerary nipples. That is more than two nipples will be present for a mm, lady. That is supernumerary nipples. Similarly, polythelia, that is also called multiple nipples. Along the milk line, multiple nipples will be present. And in these conditions, we will go for excision. That is the accessory breast or the accessory nipple that will be excised. That is the treatment. Then another condition is asymmetric breast. Usually, the breast develop at the same pace, but occasionally one breast will be developing rapidly, or one breast will be developing slowly in comparison to the other. So such kind of that asymmetry can occur in case of the two breasts. So that is another congenital anomaly that can occur. And another one is gynecomastia. Gynecomastia, the term will be familiar to you. That is when there is breast-like swelling in males. That condition is called gynecomastia. That is, the breast is enlarged to certain extent, and the two in males. That is the gynecomastia condition. So that is the main diseases which we have to see in case of congenital anomalies. Next, it is inflammatory. In inflammatory condition, main uh, disease or main pathology that is related to the breast is the breast abscess or the mastitis. So, mastitis or breast abscess, it can be acute bacterial mastitis. That is, when it is of bacterial origin, it is called acute bacterial mastitis. When there is so much of pus collection inside, it can be pyogenic mastitis. And due to lactation, during the lactational period, mastitis can occur. That is called lactational mastitis. Or it can be based on the uh, site where it is being occur. Means it can be intramammary mastitis, retromammary mastitis, subareolar. So based on the location, the mastitis can occur. That is mainly the inflammatory process in and around the breast. That is the pathology that is being involved. It can be given under the heading of breast abscess or mastitis. So, lactational breast abscess, as the name suggests, first we will tell about that. As the name suggests, it is encountered during lactation, and the precipitating factors are crack or fissure in the nipple. That is, dry skin and all will lead to crack or fissure in the nipple. Then, retracted nipple, that can means in that conditions there is chance of the nipple will be prone to infections, because cleaning of breast will be a problem in case of that retracted nipple. That is one the another precipitating factor. Then other than that, improper cleaning of nipple, infection from the mouth of baby. Then due to once the breast have had an injury or a trauma, and as a result one hematoma have occurred, and when this hematoma becomes infected, that also can lead to breast abscess. So these are the precipitating factors for lactational breast abscess. What is happening in this condition is that the cracked nipple will be present, or in that condition sucking in cracked nipple, when it is done, what happens is that the staphylococcus aureus bacteria, which is present in the oropharynx of the baby, that will be entering into the breast, and it will proliferate intraductally, and it will block the duct. Due to this blocked duct, what happens, the milk will clot, and that will ultimately lead to a cellulitis stage of the breast. And once the cellulitis stage, it is not identified and it is not properly treated at that time, what happens, that cellulitis stage will progress into a stage of abscess. So that is the end stage, means that will be the condition when the breast abscess is manifested. That is what is happening in this breast abscess condition. In non-lactational breast abscess, it occurs in patient with duct ectasia. That is, duct ectasia means the dilatation of lactiferous ducts due to muscular relaxation of duct wall. So it can be due to duct ectasia or periductal mastitis. Due to bacterial infection, periductal mastitis can occur, and ultimately it can lead to breast abscess without even the presence of, or without even the relation with, there will not be any relation with the lactation. So that is what is happening in non-lactational breast abscess. And mainly this non-lactational breast abscess, it is common in diabetic and immunosuppressed individuals. In breast abscess, the clinical features we have already discussed that first it will be a stage of cellulitis. In that stage there will be severe throbbing pain in the affected breast. The breast will be red, it will be tense, mm, on touch or on palpation it will be tender, warm to touch, and there will be browny induration also. That is the stage of cellulitis. Then another one is the stage of abscess. Stage of abscess, as the cellulitis stage is progressing, it results in stage of abscess. And in that stage, what happens? There will be high grade fever, there will be chills, rigors, and fluctuation also will be there. That is, from the stage of cellulitis, there is a stage when there is pus formation inside or pus collection inside. So fluctuation also will be felt in the later stage. And again, if it is untreated, after the stage of abscess also, if it is untreated, what happens? The abscess will rupture. The abscess may rupture through the skin, and it results in the necrosis of the skin of breast. Then ulceration can occur, and purulent discharge will be start coming from the nipple. And in addition to that, in non-lactational breast abscess, a paste-like material discharges in that condition. And the treatment, uh, when we tell, mainly, uh, as it is a part of infection, one thing is we can go for antibiotics. And if there is associated fever and all, antipyretic, anti-inflammatory drugs can be suggested. Then abscess, that is in the stage of cellulitis. Once the abscess have occurred, that is, if the pain and tenderness does not subside by 48 hours after antibiotics, then we should not wait. That is, then you have to understand that there is a need of IND. And there, the best treatment of choice is IND only. In the abscess stage, the treatment suggested is IND. Other than IND, if needed, USG guided aspirations also can be done. That can be tried to avoid surgery. So IND of breast abscess, mainly how it is done. Mainly it can be, the position of the patient will be supine, general anesthesia, or local. We can go for that. Then after proper cleaning and draping, mainly the incision will be in radial direction. That is for cosmetic purpose. That is about 5 to 6 centimeters radial direction. Incision is made over the swelling, and the incision should be made at the point of maximum tenderness. And similar to other abscess drainage, we can drain out the contents. And if needed, means this incision is made, we will drain the contents. Then we will check for, means we will insert our finger, and we will see if break the localize, and completely drainage is being done. And another incision is made on the dependent position. That is to prevent the accumulation further. For that, we have to uh, do an incision on the dependent position, and a corrugated rubber drain is brought out through this incision, so that proper drainage is happening. Otherwise, there is chance of recurrence. So to avoid that, we have to go for a counter incision. That is, an incision is made on the dependent position, because the dependent position, there is more chance that again there can be a pent up of the pus. So to prevent that, a counter incision is also made. And when the cavity is a big one, means after the drainage, after breaking the loculi and all, if it is so big, it is told that we have to pack the cavity with roller gauze. That to appropriate antibiotic solution, or mm, for um, wound healing can be promoted by using appropriate medicines. And in that way, the cavity can be packed. Usually, if the infection is very severe, we will not close the incision. Otherwise, suturing means once the drainage is removed after 48 hours, or when the discharge is minimal, the drainage is removed, and wound also is sutured in case of there is no much infection if it is there. And the post-operative care, we have to go for antibiotics. Then dressing should be changed every day. That kind of, and see for the complication, hematoma. Such kind of complications can be present if there is, if the proper evacuation is not done, there is a chance of hematoma formation. So that also have to be seen. And the, another thing which have to be advised is that uh, in cellulitis stage or in abscess stage, whatever it is, better the child should not be um, fed from that affected side. And in case if the both the breasts are affected, it is told that the breast should be emptied and the milk should be boiled for 5 minutes and then it should be given to the child. Similarly, for cracked nipple, proper hygiene maintenance, such kind of advices also have to be given to the patient. So that advices should be given in addition to that. Then the complications on breast abscess, it is mainly antibioma formation. Antibioma, you might have already heard about antibioma. That is continuous administration of antibiotic. That is, even after the formation of abscess, there is continuous administration of antibiotic, and that will lead to the formation of antibioma. So, because of means that is a one complication that can happen to this breast abscess. Then, as we know, there can be sinus or fistula formation if it is left untreated. Then skin necrosis can, means as the infection is progressive, the skin necrosis can happen. Then recurrent infection means if it is not properly drained, there can be chance of recurrence. Then bacteremia, septicemia, that is complication of that infection. Once the infection is not controlled, that can lead to other complicated um, conditions also. So that is about breast abscess. Next is fibroadenoma. Fibroadenoma means adenoma, it is a benign tumor uh, of epithelial origin and it is derived from glandular tissue. And fibroadenoma from the name, it we have to understand that it is a new growth composed of fibroadenoma, that is both fibrous and glandular tissue. So that is fibroadenoma. What happens is there will be hyperplasia of a single lobule of breast. That is what is happening in this condition. And fibroadenoma, it is the more common benign tumor of female breast, and mainly the affected age, it is young females of 15 to 25 years of age. That is the commonly occurring age. Then different types it is told, like grossly it is divided as soft fibroadenoma, hard, and giant. Soft means it will be common after 30 years. Hard means common before 30 years. And giant means when the fibroadenoma is having a size greater than more than 5 centimeters, it is called giant fibroadenoma. That is the gross classification. Microscopically, it is classified into intracanalicular and pericanalicular. Intracanalicular means it will be large, it will be soft, there will be less fibrosis. uh, the means proliferation means due to the proliferated surrounding connective tissue pressing on them, what happens is that it will be cellular, will be having distorted duct. That is intracanalicular, large, soft, less fibrosis, and proliferation is happening um, to the surrounding connective tissue. Then pericanalicular, it is just the opposite. That is intracanalicular was large and soft. Here it will be small and hard. And that was less fibrous. Here it will be mainly fibrous. It was, and stroma will be having a normal duct. There it was distorted duct. So that is the main difference. And this pericanalicular variety, this kind of tumor can be felt very clearly and it moves sufficiently within the breast substance. So it is called breast mouse. Pericanalicular variety is called breast mouse as it moves sufficiently within the breast substance. That is another important term which you have to remember, breast mouse. And the clinical features of fibroadenoma, mainly it is a painless lump in the breast, and how the appearance of breast will be. Breast will be smooth, it will be non-tender, and the consistency will be firm to hard, and the swelling will be well localized. It move freely within the breast as we have to, and the lymph nodes will not be involved. So the axillary lymph nodes are not enlarged in majority of the cases. And the investigations we can go for this, as already we have told, means mammography, FNAC, then UST. These kind of investigations can be suggested. And the treatment mainly it is excision of lump. It is in intracanalicular, the lump is deeper and peripheral, and it can be removed by submammary incision. That is called Galliard Thomas incision. And pericanalicular, it is more superficial, so it can be removed by periareolar incision, Webster's incision. And that is the incision how it should be done. Then other than that excision of the lump, cryoablation means use of extreme cold to destroy the tissue under local anesthesia, that is cryoablation, that can be done. Then enucleation, that is completely the organ can be removed, that is a surgical operation where the cyst or tumor can be completely removed, that is called enucleation. So that also can be done in case of this fibroadenoma condition. So fibroadenoma, it is a benign tumor. It is a new growth composed of both fibrous and glandular tissue. Different types it is told. The clinical features, it is a painless lump. The breast will be smooth, non-tender, firm to hard in consistency. It move freely within the breast. Then the axillary lymph nodes will not be enlarged. Investigations, mammography, FNAC, UST, this will be helpful. Treatment, excision of lump is the main treatment. Then cryoablation and enucleation also can be done in case of fibroadenoma. Next is duct papilloma. Duct, you can see in the image, that is, it is a single wart-like growth in one of large lactiferous duct. So in the duct, a wart-like growth is happening. That is called duct papilloma. So papilloma, it is a wart-like growth, and here it is, the growth is present in one of the large lactiferous duct. So it is called duct papilloma. And what happens? This papilloma will block the duct, and it will cause ductal dilatation. That is the effect. Means due to the duct papilloma, there will be blockage of the duct, and as a result, there will be ductal dilatation. Clinical features, mainly the age, when we see the middle aged women are more affected, then bloody discharge will be present from the nipple. Then just beneath the areola, it will appear like a small swelling. And when we palpate the area just beneath the areola, if we palpate, there will be discharge of blood. That is the main features present. Ductogram is the investigation suggested, and treatment is microdocectomy, means complete excision of the duct. You can see in the image, that is the end product, you can means end result. The last picture, you can see that the duct, it is completely excised along with the tumor. That is microdocectomy. So that is about duct papilloma. It is a benign single wart-like growth in the lactiferous duct, and as a result of it, there will be blockage in the duct. Finally, it results in ductal dilatation. And the clinical features, bloody discharge will be present from the nipple, and there will be a small swelling felt beneath the areola, and on palpation of that area, there will be discharge of blood. Investigation, ductogram can be done, and treatment, microdocectomy can be suggested. Next, it is about phyllodes tumor. Phyllodes tumor, phylloid at the word meaning is leaf like. It is a benign tumor of breast. Mm, it grows rapidly and it attains a great size. It contains cystic spaces with leaf like projection. So it is given the name phylloid. And even though we have told that it is benign, there is a chance that it is considered as borderline or malignant. Means if we tell that 85% of the phyllodes tumor, it will be benign, but still the 15% belongs to the borderline or malignant category. So that is about phyllodes tumor. Clinical feature, when we see, it is more common in 30 to 50 years. usually it will be unilateral. Most of the cases it will be unilateral, and it will be having a bosselated surface, that enlarged surface, that bosselated surface will be present. The swelling, it will be smooth, it will be soft, non-tender, fluctuant with necrosis of skin due to pressure. Means, as we have told, it is rapidly growing, so due to that pressure and all, there can be skin necrosis. Then the skin over the breast will be stretched, it will be shiny, and there will be reddish discoloration, and also dilated veins will be present over it. Tumor, considerably it will be warmer, and the tumor, it is not fixed to the skin, it is not fixed to muscle wall, chest cavity, and there is no retraction of nipple also. Means you can see the image, there is no retraction of nipple in case of Phyllodes tumor. And the discharge, it can be serous fluid, and because of that, because serous fluid is discharging from the nipple, it is also named as serocystic disease of Brody. Another name for Phyllodes tumor is serocystic disease of Brody, and the reason told is the discharge coming from the nipple will be serous. That is the clinical features of Phyllodes tumor. Then treatment, if it is small, it is told that wide excision of the lump or subcutaneous mastectomy can be done. If it is giant, we told it grows more rapidly and it attains a great size. So if it is giant, it is told that either simple mastectomy or quadrantectomy can be done. So that is the treatment for Phyllodes tumor. Then next main disease or main condition we have to see is the breast carcinoma. And breast carcinoma, it is the second most carcinoma in females, that is after CA of cervix. This breast carcinoma is considered as the most common carcinoma in case of females. That is one thing. And the three W's are told in case of this, that is white, western, and women. So more in white race, and that too African American, and less in Japan, Taiwan, etc. And women, main, we know it will be common in women. So three W's are told in relation with this disease. And then about the etiology, main thing, age, it is told that below the age of 20 years it is rare, but high incidence is found in between 40 to 60 years of age. So the incidence, it is told that 40 to 60 years of age it is having high incidence, and below the age of 20 it is rare. And a few other syndromes will be associated with this breast carcinoma. Means certain diseases like LFS, Li-Fraumeni syndrome, that is it is a rare disease with the familial breast cancer, and it is associated with the uh, sarcoma and leukemia, etc. So such kind of syndromes can result in breast carcinoma. So that is another etiology. Then childbearing and infertility. It is told that this breast carcinoma, it is more common in nulliparous women. And next etiology, mainly it is increased regarding the diet. That is, there is an increased risk in postmenopausal obese women, and those who have the habit of taking alcohol, or excessive saturated fat intake, and fried uh, foods, such kind of diet, those who are diet rich in saturated fatty acids, this can influence the risk of developing breast cancer. So that is another um, etiology tool. And then another thing is endocrine. That is the endocrine means the role of exogenous hormones, particularly oral contraceptives, then hormone replacement therapy, that have some um, relation with the development of breast cancer, it is told. That is, short means for a short duration, if small dosage of exogenous estrogen therapy is required, that is okay. But when it is in large amount, when it is in a continuous, or when it is for a prolonged period, that can be a risk for the development of breast cancer. So endocrine cause is also means considered under this etiology. Then when we see the um, gender, of course we have already told, it is females who are more affected. It is told that 99% females and 1% males. Means 1% males mean, especially it is in the case of gynecomastia, the males who have having that gynecomastia condition, there is a chance that 1% chances in that case of males, this incidence. Then another thing is genetic cause. Genetic cause, genes are associated with the, means breast carcinoma 1 and 2 genes are there. They can be associated with the increased risk. It is told like 3 to 4 times more likely to develop in women with the first degree relatives who had breast cancer. They are having more chance. Then age of menarche and menopause, that is also told. That is, the girls whose menarche occurs before the age of 12 years, they have a relative risk. Similarly, menopause also, means whose menopause started before the age of 45 years, there is a risk. It is told like that. The age of menarche and menopause is also considered under the etiology. Then another thing, it is told about any history of radiation at the chest, that also can be a risk for this disease. Then if there is any benign duct disease, any other pathological entities such as multiple papillomatosis, hyperplasia, etc., that also can be uh, associated with an increased risk of breast cancer. So these are the main etiology told. Then next it is about the site, means we have told about different quadrants. So regarding that, how common it will be, it is told that 60% of breast carcinoma arise in the upper outer quadrant, 12% in upper inner quadrant, 10% in lower outer quadrant, and 6% in lower inner quadrant, 12% in central or subareolar region. So when we consider the site of this carcinoma, more it is told that it is common in the upper outer quadrant. That have to be remembered. And next is about the classification of breast carcinoma. So classification, one classification is about the symmetrical, means either it can be unilateral or it can be bilateral. Then another one is ductal carcinoma and lobular carcinoma. Ductal carcinoma means carcinoma arising from the lactiferous ducts, that is around 90% it is told. And lobular carcinoma means carcinoma arising from the lobules, that is around 10%. Then it is another class, that is, so two types of classification it is. One is unilateral, bilateral. Next is ductal and lobular. Third classification it is unilateral, multifocal, and multicentric. Unilateral, it is known. Multifocal means the tumor tissues within the same quadrant at multiple foci. So multifocal means multiple points will be there, but the tumor tissues will be in the same quadrant. That is multifocal. Multicentric means tumor tissues within the same breast at multiple foci. It is not the same quadrant, it is the same breast. So that is another classification. Unilateral, multifocal, and multicentric. Next classification is infiltrating carcinoma and non-infiltrating carcinoma. Infiltrating carcinoma means that infiltrate into the basement membrane. Non-infiltrating, which are not infiltrating. So these are the main classifications of breast carcinoma: unilateral, bilateral, ductal, lobular, unilateral, multifocal, multicentric, and infiltrating and non-infiltrating. Then infiltrating carcinoma is again uh, divided into many types: serous carcinoma, inflammatory carcinoma, medullary carcinoma, colloid carcinoma, etc. Serous carcinoma, it means hard to touch, and it will be white or white yellowish in color. There will be more fibers, it will be less cellular, and in serous carcinoma there will be retraction of nipple. We have already told it is infiltrating type, so infiltration of skin and fixity to chest wall will be there, and because of all these things there will be retraction of nipple also. And next one is medullary carcinoma. Medullary carcinoma, it is little softer, it feels softer, it will be well circumscribed, then it will be bulky and hemorrhagic. It will be having uniform consistency also, and consistency it is told like brain like consistency. It is told that it is also called encephaloid type, that is brain like consistency the tumor will be having, that is medullary carcinoma. Then it is inflammatory carcinoma. So among the carcinoma types, inflammatory carcinoma is considered as the most aggressive type of carcinoma, and this is more seen during the pregnancy and lactation. So inflammatory carcinoma, uh, means from the name we can understand that it mimics the breast abscess, that is inflammatory. From the name, that inflammatory signs we can expect, that is there will be redness, pain, that sudden enlargement, those kinds of features will be present in this tumor. And because of the presence of these kind of features, redness, pain and sudden enlargement, it mimics the breast abscess. But the difference between breast abscess and this is that we have already learned in breast abscess there will be fever, uh, mm, rigors, chills, etc. But here in case of this inflammatory carcinoma, there will be absence of fever, and but in addition to that, there will be presence of gross pudiorange appearance. So we have already mentioned classical sign of breast carcinoma is the pudiorange sign. So in addition to that redness, pain, etc., if fever is absent and if pudiorange sign is present, we can differentiate it from mastitis. And this inflammatory carcinoma, we have told it is the most aggressive type. So it is told that it is rapidly, it will metastasize to the chest wall, to the bone, lungs, etc. So the aggressive type, mainly the metastasis is happening in a rapid manner, that too to the chest wall, bone, lungs, etc. And because of that, what happens, it will be giving a, or it will be ending as a worst prognosis. And in addition to that, there will be lymphatic involvement, lymphatic blockage will be there, lymphangitis will be there. So as a whole, it will be uh, considered as having a prognosis, or which is having a poor prognosis. So that is about inflammatory carcinoma. Then it is colloid carcinoma. Colloid carcinoma, it will be more in elders. There will be production of mucin intracellularly and extracellularly. Mucin will be produced, and the cut surface will be glistening, glaring, and gelatinous. That is colloid carcinoma. So these are the main classification or types of that infiltrating carcinoma. Next is about the clinical features. If we tell, in addition to the above said things, if we summarize the clinical features, first thing is lump in the breast. That will be the main feature, and we have to check, means where it is present. Mainly it will be in the upper outer quadrant, then the consistency will be firm, it will be painless in the beginning, then um, whether it is hard or soft, based on the type there can be variation. Irregular surface will be present, and in inflammatory carcinoma, etc., it will be painful in the beginning itself. So that is about the lump. Then in addition to that lump, what and all things will be there? There can be bleeding per nipple, then retraction of nipple, that is due to the infiltration of lactiferous ducts, there can be retraction of nipple. Then ulceration or pudi orange appearance will be present, that is due to the obstruction of the dermal lymphatics, the opening of sebaceous glands and hair follicles will be buried in the edema, and that will give rise to an orange peel appearance, that is called puri orange appearance. That will be present, or sometimes ulceration will be present. And when we examine the lymph nodes, there will be enlarged axillary lymph nodes also. So these are the main clinical features. And in addition to these features, if there is metastasis happening, there can be backache, chest pain, ascites, hemoptysis, dyspnea. These kind of associated complaints will be there if there is a metastasis being happening. And same thing in breast carcinoma also, another main um, thing we have to include is the examination only, that already we have discussed, that is inspection. Proper positioning of the patient is needed. The nipple have to be examined to see whether, means in ductal carcinoma and all, bloody discharge will be there, then that retraction of nipple, then whether there is retraction towards the tumor away from the tumor, etc., that have to be noted. Then the level of nipple means fibrosis and all, if there is, means due to the growth, if there is fibrosis and all, that level of nipple will be elevated. Then in some conditions like eczema, the nipple will be destructed. So for that, the nipple have to be examined. Skin over the breast, if there is any puckering or dimpling due to the infiltration, that also have to be seen. So about palpation, means in case of breast carcinoma, especially in inflammatory breast carcinoma, there will be local rise of temperature. There will be also the lump can be clearly will be the lump. The commonest site we have already told, upper outer quadrant. So while palpation, we can make it more clear. Means the examination can be done in more prompt way than the how it is, to touch how it will be, whether it is hard, irregular, firm. Usually carcinoma will be hard, irregular and firm. So on palpation that can be clearly manifested. Then mobility can be checked, whether it will in fibroadenoma, we have told it will move within the breast tissue, so that can be made clear. Then skin fixity to skin, other structures that can be examined properly in the palpation. Then axillary lymph node examination can be done. Then examination for distant metastasis, like abdominal examination for secondaries in liver. Then respiratory system examination to rule out effusion, bony tenderness, such kind of distant metastasis also can be examined. Next, about the spread of carcinoma of breast, one thing is local spread. That is adjacent structures, the infiltration can occur. Then through the lymphatics, through the central group, pectoral, lateral, and subscapular, suprascapular lymph nodes, it can spread. So that is another local spread. Then lymphatic spread. Then blood spread also. That is secondaries in bones, secondaries in brain, malignant pleural effusion, liver. So these kind of spread can occur. So mainly local lymphatic and blood spread can occur in case of spread of carcinoma breast. Then another important thing is the TNM staging. TNM staging almost it is earlier also we have discussed about the TNM staging. So here in case of TNM tumor, T0 means no evidence, T1 2 centimeter size, T2 2 to 5 centimeter, T3 more than 5 centimeter, to T4 extension to chest wall and skin. Nodal status, N0 means no nodes, N1 there will be palpable mobile axillary lymph nodes, then N2 palpable fixed axillary lymph nodes, N3 means other lymph nodes also will be involved, especially the infra or supraclavicular nodes. Metastasis, M0 is there is no metastasis, M1 metastasis is happening. So that is the TNM staging. And regarding the investigations, already we have told mammography is a important investigation which can be suggested. That is from mammography we can identify the identify, or we can make sense how much the conditions we can make out from the mammography. Then USG of breast also will help to detect the solid cystic lesions, so that will be helpful. Then FNAC biopsy, then investigations for the secondaries like chest X-ray, abdomen USG, that also can be suggested as investigations. And treatment mainly breast carcinoma, or mainly in carcinomas the main treatments which we will suggest is, one thing is surgery, then radiotherapy, hormonal therapy, and chemotherapy. Surgeries, mainly it is lumpectomy, that is the tumor along with the 2 centimeter of normal tissue, it will be removed, that is local wide excision. Along with the tumor, 2 centimeter of the normal tissue also will be removed. uh, that is especially in case of a tumor less than 4 centimeter, that is called breast conservative therapy. That is, we are not removing the breast as such, only that lump along with the part of normal tissues being removed, that is called local wide excision or lumpectomy. Then quadrantectomy, so as the name suggests, the tumor means the quadrant in which the tumor is situated, that particular quadrant is being removed, that is quadrantectomy. Then total mastectomy and axillary clearance, that is the entire breast tissue will be removed, and both the pectoralis major and minor will be preserved, breast tissue will be removed, that is total mastectomy and axillary clearance. Then patty mastectomy, that is breast tissue with the pectoralis minor will be removed, and along with that axillary block dissection is also there. That is another surgery. Means in total mastectomy we have preserved the pectoralis major and minor. Here in this patty mastectomy, the breast tissue with the pectoralis minor is removed. Then Halsted radical mastectomy is there. That is entire breast tissue with the both pectoralis muscles are removed. So different kinds of surgeries are told. That is depending on the part which is being removed, or the tissue, the level of tissue which is being removed. Based on that, different kinds of surgeries are told. Mainly local wide excision or lumpectomy, then quadrantectomy, then total mastectomy and axillary clearance, patty mastectomy, Halsted radical mastectomy. So these are the different surgeries. Then radiotherapy. Radiotherapy, when the tumor margin is positive, when the inner quadrant is involved, when pectoralis major is involved, means after breast conservative surgery and all, we can go for radiotherapy. Similarly, hormone therapy, tamoxifen, that is, it is an anti-estrogen. It will block the estrogen receptors. So such kind of hormone therapies can be done. This will help in reducing the recurrence, and it will be useful in metastasis also. And next thing is chemotherapy. Chemotherapy, it is indicated in premenopausal patients where the lymph nodes are positive in axilla. In that conditions, chemotherapy is indicated. Uh, we have heard about 5-fluorouracil, cyclophosphamide. These are the drugs which can be used. So that is the treatments mainly which is indicated in case of breast carcinoma: surgery, radiotherapy, hormonal therapy, and chemotherapy. So that is about breast carcinoma. And then about the Ayurvedic correlation, or which you have to learn in case of this topic, disease of breast. It is mainly about the sthana vidradi. Sthana vidradi, when we see about the sthana vidradi, it is taken from the Ashtanga Hridaya uh, Samhita. It is Ashtanga Hridaya, and it is told that Evameva Stanasira Vivrata Prapya Yoshitam Sutanam Garbhininam Va Sambhavet Shvedurgana Stane Sadugde Adugdeva Bahya Vidyadi Lakshana Nadinam Sukshmavattatvat Kanyanamna Sanjayate. So this is the reference taken from Ashtanga Hridaya Nidana Sthana. Vidradi, it is told, and while mentioning about other Vidradis, there is special mentioning of this Sthana Vidradi. Whereas in case of Sushruta Samhita and all, it is told about Sthana Roga. There is no particular mentioning about Sthana Vidradi as such. Sthana Roga, it is told in detail. So here in Sthana Vidadi it is told that Evameva Sthanasira Vivrata Prapya Yoshitam Sutanam Garbhininam Va Sambhavet Shvedurgana. That is when the pregnant lady or lactating mother, Suta and Garbhini, Sutika or Garbhini state, when in that lady, what happens? Due to different kinds of nidana, that is apatyahara vihara, what happens, doshas will be getting vitiated, and it is told evameva sthana sira vivrata, that is the sthana siras will be vivrata, will be dilated uh, in that stage. Because of that garbhavastha and the sutika avastha, there will be vivrata sthana siras present in the lady. And what happens, tanesa dugde adugdeva bahya vidyati lakshana, and the doshas getting vitiated will reach the breast through the srodhas, and it forms a sambhavet shvayadhur khana. It will result in a hard swelling. Nadinam sukshma vatratvat kanyanam na sajayate. And it is told that as the mm, vakta means the openings of the uh, nadis, in case of kanya it will be minute openings, so this condition will not be occurring in Kanya. It will be mainly occurring in the Garbhini or Sutika Avastha, and it will not occur in Kanya as the channels or as the openings of the channels is very minute. This condition will not happen in Kanya. That is told in the Ashtanga Hridaya text. So, Evameva Stanasira Vivrata Prapya Yoshitam Sutanam Garbhininam Va Sambhave Shvedhurghana Stane Sadugde Adugdeva Bahya Vidyadi Lakshana Nadinam Sukshmavaktvatvat Kanyanam Nasa Jayate. And the treatment, it is told Tanaje Pranavat Sarvam Natvenam Upanahe Padayet Palayan Sanyavahini Krishna Chuchuko Sarvaswam Adhyavastasu Nirduhida Cha Tatstanam. So it is told that except Upanaha, the other treatment same as that of Prana can be adopted here. Patana should be done, and it is told that Patayat, Palayan, Stanyavahini, Krishna, Stanava Srotas, and the Krishna Chichuka, that is the area avoiding that region or protecting. Palayan, it is told Palayan Sanyavahini, so protecting the Sanyavahini and the Krishna Chichuka, the Patana have to be done. Sarvaswam Sarvaswam Adhyavastasu Nirduhida cha Tatsana. That is, breastfeeding should be Avdukida means breastfeeding should be told. So Branavat Chikitsa can be adopted except Upanaha. Then Padana is the main karma that can be done, and that have to be done protecting the Stanyavahini and Krishna Chichuka, and better to avoid breastfeeding from the affected breast. That is the explanation given in Ashtanga Hridaya Nidanasthana. And other than that, as I have told in Sushruta Nidana 10th chapter also it is told, and but it is told about the Sthana Roga. It is not told about Sthana Vidradi. It is told about Sthana Roga, and it is told that commonly it is seen in the Prajata Stri or Garbhini. Same it is means, even though the Sthana Vidradi concept is not told in Sushruta Samhita, the matter or the description told is the same only. That is mainly it is told seen in the Prajata Stri or Garbhini, and that is due to the Dhamani Dwara Vivrita. That is the Dhamani Dwara or the openings of the channels or vessels will be dilated, and because of that this condition is occurring in Prajata Stri or Garbhini. Similar to Ashtanga Hridaya, here also it is told that not at all seen in Kanya. This condition is not at all seen in Kanya due to Samrita Dwara. That is, there will be dosha avisarana, and hence in due to Kanya there will not be. And in the same chapter, Susudana 10th chapter, Stanaroga Nidana and Sankhya, it is told similar to Nadi Vrana. That is, Shofam na Pakvam iti upekshate yo va vranam prachuram puyam asadhuvratta. That is, two causes it is told. Considering a Pakwa Shofa as an Ama Shofa and postponing the karma. Means here it will be the Bhedana karma. So, thinking that the Pakva Shofa is in the Amavastha, we are not treating it properly, and that will cause this Sthana Roga. Then a person suffering from Vrana, if that person is not following the proper patya ahara viharas etc., and if he is indulging in that ahitahara vihara without any control over his senses, then it will cause the formation of both nadi vrana and sthana roga. That is the explanation given in Sushruta Nidana 10th chapter. And 5 types it is told: vata, pitta, kapha, sannibada and agandu. And Stanaroga Samprapti also it is told. It is told that Sakshiro Vapya Dugdho Va Prapya Dosha Stanostriya Rektam Mamsam Cha Sandosha Stanarogaya Kalpade. So as I have told, the term used is Stanaroga. That is due to the Nidana, the puya formed enters into a deeper plane of tissues. And what happens? There will be Visheshan of Rakta Mamsam Cha Sandushya. There will be Visheshan of Rakta and Mamsa of the Sthana region, and that will lead to Sthana Roga. Sthana Roga Kalpade. That will lead to the formation of Sthana Roga. And where it is means in which kinds of ladies it is happening. Sakshiro Vapi Adugdo. Sakshira means Garbhini, Adugda means Prasuta. So that is the explanation given in Sushruta Nidhanasthana. And Vidradi Lakshana, we can the other Vidradi. Generally, Vidradi, whatever Lakshanas is told, that can be taken here also, except that Raktaja variety, because here it is Vata, Pitta, Kapha, Sannipada and Aganduja. So Raktaja, without taking the Raktaja variety of Vidradi, the other features can be applicable here also. Then Stanaroga Chikitsa also it is told in Sushruta Chikitsa Sthana 17th chapter. In two headings it is told, means in two different ways. That is, it is Stanya Chikitsa as well as Stanaroga Chikitsa it is told. Stanya Chikitsa, it includes Kritapana with Triphala Krita, Vamana with Nimbodaga, Madhu, etc. Then Stanya Shuddhi with Aragadadi or Mustadi Gana. Then according to dosha, in Stanya Dushti, Shamana Aushadhi can be given. That is Stanaroga Chikitsa, based on that is mainly Stanya Chikitsa it is told. Then next is Stanaroga Chikitsa. That is after examining the Stanaroga or the Vidradi, means whatever it is Grandhi or Vidri, whatever it is, after examining the Stanaroga, Vidradivat Chikitsa can be done. Vidradivat Chikitsa means Ama, Pachyamana or Pakva. We have to properly examine which is the stage, in what stage the Vidradi or the Shofa is. And after determining whether it is Ama, Pachyamana or Pakva, then it is told that for the first two avastha, that is for the Ama and Pachyamana avastha, Apatarpanadi Egadasha Upakrama, except Upanaha, can be done in case of Ama and Pachyamana avastha. Except Upanaha, why it is told? Because if Upanaha is being done, there is a chance that there can be Kodha of the Sthana that can take place. So to avoid that, it is told that except Upanaha, the Apatarpanadi Ekadasha Upakrama can be advocated in case of Ama and Pachyamana avastha. And Pakva avastha we know, means for Pakva avastha, of course, it is the Vedana that have to be done. And is the procedure, that is here also it is told saving the Dugdharini, that is the lactiferous ducts, and the Krishna Chuchuka, the areola and nipple. Chedana means Chedana here, it is like the incision. Incision should be given, and then the accumulated pus that have to be drained. And throughout the treatment of Sthana Roga, it is told that Dhatri Sthana Satatam Nirduhita, that is constantly the stagnant milk needs to be expressed out through the affected breast. Means breastfeeding, it is not advised, but the stagnant milk, because breastfeeding we are telling that we should avoid breastfeeding from the affected breast. So there is chance that means the milk production is being happening, so there is a chance that there will be stagnation of milk happening in the affected breast. So for that, it is told that Dhatri Sthana Satatam Nirduhita, constantly the stagnant milk needs to be expressed out through the affected breast. That is about the Stanaroga and its Chikitsa. And Stanaroga, when we consider the mm, Ayurveda and modern correlations. There is mentioning, there are references regarding Tristani, Asthani, and all, which we can correlate to the congenital anomalies which we have told about anorexia, polymesia, etc. So that comes under that heading. Then the hematostroma and all, agandija show file will be coming. Then the sthanoroga, that is cystitis, abscess and all. Then the Granthi means fibroadenoma, phyllodes tumor, and etc. can be considered under the